Hi everybody, today I am going to speak the topic on medical nutrition therapy for diabetes. I am Mrs. Sudha Vasudevan, Head Department of Foods, Nutrition and Dietetic Research from Madras Diabetes Research Foundation in Chennai. I come with 3 decades of richness in experience, both teaching as well as a researcher across national and international institutions. And today the topic of interest is diabetes. As you all know, diabetes is a global, every household problem. And how many of you know the word diabetes? I am sure all of you will put up your hands. It is such a household, it's becoming like a surname in each household. And so today's talk, we will be taking this medical nutrition therapy for diabetes, which you and I, all of us know as such a common term. And this will be covered in 7 modules. So much of research and clinical evidence and the public health policies and actions have taken place to covered in this module, in this entire topic, divided into 7 modules. And today in this class we will be covering the first module, which speaks about the overview of diabetes, a bit of history of diabetes and the diagnosis and the types of diabetes that you see today. Like we have everything in this world has got types, even among humans, even among men we have different sizes and shapes of people. So also in this disease we have different types of diabetes, and with these types of diabetes then we will go through a bit about the pathophysiology, how these different forms of diabetes do exist today in the world. Were they there yesterday or are they going to be there tomorrow will be our main picture for this class today. So today at the end of the class, I expect you all should have gone through and you should be able to describe all these things which are listed as learning objectives, and I am sure you would all will learn at the end of the class. The first learning objectives will be describe the current diabetes epidemic and its economic burden, know what is diabetes, screening test for diabetes, and explain the classification and various types of diabetes, and including the risk factors and the pathophysiology, or sometimes it's often called as etiology of diabetes. So let's start with the overview, the big picture. Diabetes is occurring across the countries in the globe, and the epidemic is soaring every year after year. The numbers are going up. And in fact, the latest International Diabetes Federation, a 7th release, has come and released it as 415 million people of diabetes in the world, and it is going to explode almost by another 55% in the year 2040 to have 642 million people with diabetes. In fact, to give you a very nutshell, 1 in 11 adults in the world have diabetes, and 1 in 15 has got impaired glucose tolerance called pre-diabetes. This is something like your visa stamping, you have a visa stamping to enter into the country. So the pre-diabetes tells you that any time the person might enter into diabetes very soon. So this is equally deadly with that number of people with pre-diabetes. So you can imagine the combination of people with diabetes and any time to become diabetes, so-called pre-diabetes, the volume of people in the world is going to soar high. And though type 1 is less common, the prevalence of type 1 is also increasing at the rate of 3% every year in the world. There are 5.42 million children with type 1 diabetes, and this continues to nearly double the number of people with diabetes in rural and urban areas. In fact, IDF 2015 recently even estimated that the urban environment continues to have nearly double the number of people with diabetes as compared to the rural areas with 145 million and urban 270 million. So as a result, the economic burden continues to be on the rise, with 5 to 20% on healthcare expenditure of spent on diabetes and associated complication. The death rate due to diabetes is mounting, and 1 in 6 adults die every 6 seconds in the world. This has longer impact on a healthcare system and a major threat to the sustainable economic development. In the developing countries like in India, every Indian knows somebody with a neighbor, community, And in fact, 2015, the same atlas shows in India 69.2 million people in the world. Following China is number 1, India is number 2. Like we have Mr. India, Miss Universe, you can also say now we also have Mr. Diabetes, and next to China we are the second holder, and with 1.7 million deaths occurring in due to diabetes. And in fact, if you see the comparative study of the prevalence of diabetes from 2000 onwards, it was 31.7 millions to 40.9 millions diabetes, then to 50.8, and 2011 it was 62.4 million people with diabetes. Within 4-5 years, the IDF now has declared 69.2 millions, indicating that on an average every year we have 1.5 to 2 lakhs of people. It's manufacturing, right? Diabetes is being manufactured now, more and more people, and in this rate, had we not learned to arrest, if we continue by 2040, we will have 126.5 million people in our country with diabetes. And so this is what the first time in the medical history, Indian Council of Medical Research INDIAP study was conducted, and in the phase 1 of the study, they found out 62.4 million, which I explained to you now in 2011. Now the more worrisome is equal amount or much more than that is going to be pre-diabetes, which I explained as a visa status eligible to get diabetes is 77.2 million disease. So now this overview, now you really need to pay attention to understand what is all this diabetes is. You have given us all scary figures now, ma'am. So what is diabetes? Diabetes mellitus is a group of disorder. It is heterogeneous in nature like us and characterized by chronic hyperglycemia. Hyper means high, glycemia means blood glucose, and due to altered carbohydrate, fat and protein metabolism. This results either due to a defects in insulin secretion or insulin action. In other words, you can say it is due to insufficient or inefficient on insulin, a hormone, very important major hormone in the body. So as a result of this defect, right, you can see that it affects the entire macronutrients, the energy providing macronutrients of carbohydrates, protein and fat, which you all must have learnt the macronutrients what they are. So it is so central, the entire nutritional biochemistry can be halted because of this insulin defect, resulting into diabetes. Hence you will be able to appreciate why it is heterogeneous in nature. Based on the diabetes, is generally classified based on the etiological factors as type 1 diabetes, type 2 diabetes. Absolute deficiency in insulin due to complete destruction of beta cells is called type 1 diabetes. It's mainly inflicting the young, whereas type 2 diabetes usually occurs at an older age and deceptive onset due to insulin insufficiency and resistance. Earlier terms of insulin dependent diabetes mellitus, it's called IDDM, or still earlier it was called juvenile diabetes, and non-insulin diabetes mellitus, NIDDM, or maturity onset diabetes, or no more in use at various ages. The term used were earlier based on treatment modality, which may not be appropriate because there is so much of changes in the treatment modality. Gestational diabetes is defined separately based on the unique criteria of diagnosis. In addition, counter-regulatory hormones including glucagon, epinephrine, norepinephrine, growth hormones and cortisol, all of which decreases the insulin sensitivity and subsequent hyperglycemia. Pre-diabetes includes both impaired fasting glucose and impaired glucose tolerance, diagnosed with 2 hours of glucose tolerance with 75 gram of glucose, and 1/3 of them usually progress to diabetes out of pre-diabetes. So there is a good potential to prevent this number of people getting converted to diabetes. Obesity, aging and genetic predisposition and certain medications are the common factors for the insulin resistance, meaning to say there is so much insulin in the body but it is inefficient. Asian Indian phenotype, a unique predisposition, makes this ethnic group more vulnerable to diabetes compared to white or Caucasian. So screening at population level can help detect early and possibly prevent type 2 diabetes, which is the most common type of diabetes, afflicting 95% of the diabetic population. Cost effective means risk scores could be another way to cost effectively you can screen diabetes at the early. Despite only 32 countries in the world are implemented in this risk score model to screen people in large from the population level. The main two reasons at the population level for the escalating rate of diabetes worldwide are epidemiological transition with decreased mortality due to communicable diseases and coexisting nutrition transition characterized by increasing prevalence of chronic diseases such as diabetes, mainly due to altered lifestyle like unhealthy dietary habits and poor with low levels of physical activity. And chronic hyperglycemia accentuate the risk of macro and micro complications of diabetes affecting various body systems. You will be surprised, this is not a new trend or a new phenomena. Diabetes is not just known to you and me now, it has been known to the world right from the AD 70. The Roman artists noted frequent thirst and urination. It's called polydipsia is the thirst and urination is polyuria. Diabetes mean to flow through, and further added mellitus by a London physician Thomas Willis to mean a honey like to reflect the sweet taste of urine. Even Indian ancient wisdom, 600 BC, the physician Sushruta recognized diabetes and called it as madhumeka, and the physician treated the diet as an important part in the treatment of diabetes. So it has been there for a while from ancient times, and in the modern times it is growing and it is bulging into epidemic. It's a exploding epidemic. So as a result, economic burden of diabetes is very important. Now the cost to medical care by a person with diabetes is twice that of a person having a health expenditure without diabetes. An economic burden could be due to direct and indirect costs. Direct costs include consultation to the doctor, investigation, medication, management, treatment complication, hospitalization directly associated with the physical condition of the disease. Whereas indirect conditions are cost expenditure are as a result when a person is hospitalized for so many days to get the diabetes control, he or she has been taking leave. So the indirect costs are all the loss of productivity and disability and the social security issue, and as a result the person even can push to go into a psychological depression and so on. And in fact, International Diabetes Federation estimated the mean diabetes associated expenditure to be rupees 5,795 per year in India, and a study from the southern India had also shown an annum urban spends more on healthcare expenditure to 10,000 as compared to the rural counterpart of 6,300 rupees per annum, but this number is going to add more and more every year. On an average, almost 1/4 of the annual family income is being spent by low income groups to manage diabetes. This huge economic burden of the individual and the family leads to neglected healthcare. Active comprehensive healthcare program in India today is inadequate, and thus individuals with diabetes being attended by various healthcare providers equipped with poor quality measures. Globally, a sizable proportion of people are unaware of diabetes in them at all. As you know, if in this class I can tell you how many of you are wearing glasses, I can pick up. If you ask me how many are wearing contact lens, I cannot. Whereas similar to the diabetes, by looking at a person, you cannot pick up and say he or she, oh, by the look I can say he or she has got diabetes. It's not possible. So it is such a silent, it need to be screened, it need to be tested out to find out a person. So it is so silent living inside the body. So it is unaware. Almost half the size of the people with diabetes remain undiagnosed. So screening at population level can help detect early and possibly prevent type 2 diabetes, which is the most common type of diabetes afflicting 95% of the diabetic population. Cost effective means risk scores could be another way to cost effectively you can screen diabetes at the early. Despite only 32 countries in the world are implemented in this risk score model to screen people in large from the population level. The main concerns to consider screening program: a bigger proportion of people with diabetes remain asymptomatic because it's silent. Sizable proportion of newly diagnosed show already a microvascular. So this tells you we have to screen them much early. Onset of uncontrolled diabetes with the long-term complications that could be averted by early screening and intensive therapy to better glycemic control. Early treatment and detection, even the comorbidities like hypertension and dyslipidemia, can reduce the complications such as cardiovascular burden in people with type 2 diabetes. And vulnerable ethnicity like Asian Indians, like I told you before, we Indians are more prone to abdominal obesity. Same vulnerable ethnicity like Asian Indians, where diabetes sets in a decade earlier, hence at an younger age, so we need to screen them early. Asian Indians have stronger family history and warrants robust screening measures. So the age at risk is individuals greater than 35 years as against the Western maybe 45 greater. Women with the history of gestational diabetes, meaning to say developed diabetes during pregnancy or delivered a baby greater than 4 kg birth weight. Existing pre-diabetes, dyslipidemia, also again suggestive that person is more likely to have diabetes. Other medical conditions like polycystic ovary syndrome is also an important candidature to screen for diabetes. As suggested, screening protocol adopted has been illustrated in figure 1. So what is diabetes in detail? So a diabetes is a metabolic disorder characterized by hyperglycemia due to altered carbohydrate, protein and fat metabolism, resulting from either inefficient or insufficient insulin action or combination both. As a result, there is an overall dysregulation of fuel utilization, leading to impaired cellular uptake of glucose, fatty acids and amino acids. Diabetes mellitus increases the risk for micro and macrovascular complications such as heart disease and stroke, a macrovascular, and renal and retinal, which is a microvascular, those who have especially with a sedentary physical activity pattern. And Asian Indians with genetic predisposition is much more, makes them vulnerability. Diagnostic criteria: diabetes is best diagnosed with oral glucose tolerance test called OGTT, and even the early stages of the disorder like pre-diabetes can be detected. On a defined glucose drink, 75 gram dissolved in 200 ml water, both fasting sample before the glucose drink and 2-hour post plasma glucose measured, as against earlier method where blood samples were collected at fasting and every 30 minutes for 2 hours. Now only the fasting and 2-hour post glucose are considered for diagnosis. Pre-diabetes occurs before the development of type 2 diabetes and is further categorized as IFG and IGT as explained before. Blood and urine samples are collected for every 30 minutes from 0 to 2 hours. The table below shows the cutoff fasting and 2-hour post glucose values for diabetes and pre-diabetes. It can also be randomly picked up with a random sample if the value is above 200 mg per deciliter along with symptoms of diabetes. And with the glycated hemoglobin A1C, which gives you the overall 3 months control if the values are greater than 6.5. So many studies have shown that 2-hour plasma glucose value after the OGT pick up more people with diabetes than the HbA1c cut points. Thus, OGTT is a gold standard and confirmatory test for diabetes and pre-diabetes. So the diagnostic criteria, the figure clearly explained. The screening protocol to give the 75 gram of oral glucose test tolerance, and before the glucose drink is loaded, the fasting plasma glucose value, if it shows less than 100 milligram per deciliter, then that person is said to be normal. So you need not worry at all. Then if the plasma fasting glucose values are 100 to 125, then you have to give them the 75 gram glucose and then proceed further. And in the 2 hour post glucose, if it is greater than 140, they are called as impaired glucose tolerant person, and less than 200. If the 2 hour glucose clearly shows greater than 200, it confirms with fasting value of greater than 126 and 2 hour value greater than 200 is diabetes mellitus. And this is what is given in this table: the fasting blood glucose, empty stomach after overnight fast of 8 to 10 hours. If it is pre-diabetes, the value is 100 to 125, and diabetes greater or equal to 126, and 2 hour glucose taken is 140 to 199 and greater than 200. And in GDM, gestational diabetes, there are the latest American Diabetes Association and International Diabetes Federation suggest a 75 gram glucose load with the fasting value greater than 92 and 1 hour plasma greater than 180 and 2 hours 153. Or to save time with the pregnant women, sometimes they do the 50 grams. If the values go more than the 180, then they do the extended GTT with them for 3 hours. So, high blood glucose in pregnancy can be categorized into 3 types. One is gestational diabetes, and diabetes first diagnosed during pregnancy, and diabetes diagnosed before pregnancy. Slightly elevated blood glucose first detected in pregnancy is called gestational, whereas consistently higher blood glucose detected is called diabetes detected in pregnancy. The International Association for Diabetes in Pregnancy Study Group, IADPSG, recommend one-step strategy to consider 75, which I showed you the values a while ago, and 1 to 2 hours during 24 to 28 weeks of gestation after overnight fast. Whereas the other two-step strategy recommends 50 gram glucose load first and then 1 hour, and if the value is greater than 140, then 200. OGTTs recommend to measure plasma glucose 1 and 2 and 3 hours. Diagnosis of GDM is confirmed based on the cutoff points. So now we have learned how the overview and what is the diabetes and how the screening needed and the diagnostic criteria. So having diagnosed a person with diabetes, the next step for us is to see what are the various types. How do you classify what type of diabetes the person has got? So there are generally 2 broad types: type 1 diabetes and type 2 diabetes, which I mentioned in the overview. It is no more called IDDM and NIDDM, and gestational diabetes and other types of diabetes. And type 1 diabetes, where the beta cell destruction due to autoimmune leading to absolute insulin deficiency, while type 2 diabetes is characterized by the lazy or insulin resistance with relative insulin deficiency that can progress over time. This type of diabetes is inherited and has multiple genes contributing to its cause. Environmental factors combined with genetic predisposition trigger the onset of diabetes. Gestational diabetes, any glucose intolerance with the onset of first recognition, usually in pregnancy, usually condition reverses after the pregnancy, but it makes the women more prone to the risk of type 2 diabetes in later. Other types of diabetes are usually referred as those caused by the reasons such as neonatal diabetes, the maturity diabetes of the young, cystic fibrosis or exocrine pancreas, or drug-induced diabetes. Treatment drugs for HIV and AIDS and post-organ transplant can also trigger diabetes. So the best way is the best mantra and the biggest solution today available: prevention or delay the onset of diabetes. Many short and long-term randomized control trials have shown that by effective screening and intervention strategy with high-risk individuals, as mentioned in the previous section, the rate of diabetes can be significantly reduced. Intensive lifestyle modification can help. In fact, the international programs of diabetes primary prevention program DPP have shown 40 to 60% reduction with the lifestyle correction alone without the drug treatment. Now we'll move on to the pathophysiology. Now we know the diabetes types, and now we have to identify why this many types, because the pathophysiology could be different. So there is a general changes in the body metabolism and chemistry. So the energy regulation one need to understand because it deals with the macronutrients. So the role of hormone insulin is a primary hormone produced by the beta islet cells, and it controls the metabolism and storage of body fuels, macronutrients. Insulin is released in proportion to the meal ingested, and even in the fasting state it sustains a basal amount of insulin. It is a main signaling hormone in the body for both the fast and the fed state. Ingested nutrients will typically stimulate half of the post-meal insulin, and the rest is facilitated by the gut hormones like glucagon, like peptide 1 GLP produced in the distal ileum by the L cells account for the 80% of the incremental insulin, increase in the response, whereas the 20% balance comes from the gut hormones. And fuel regulation in fed and fasting and stress stages, serum insulin levels stimulate storage of energy after feeding a large meal, whereas after an overnight fasting, low mobilization of energy from storage facilitated by hormone glucagon and counter-regulatory hormone. Under stressful situations such as hypoglycemia, trauma and exercise to promote glucose production and mobilize fatty acid to release energy. So even if there is not enough glucose, then from the fats dissolved to provide glucose. Then pathophysiology of type 1 diabetes is characterized by the same absolute insulin deficiency by the cells. It leads to onset of type 2 diabetes, where the clinical symptoms are very sharp, and through the pathophysiology, damage is slow and progressive process. Symptoms and hypoglycemia develops only after 90% beta cells destructed, and autoimmune, as I mentioned earlier, however, exact causative factor is still unclear. Environmental to trigger at the time of diagnosis, 85 to 90% type 1 diabetes have more circulating autoantibodies and antibodies like islet cell and decarboxylase GAD antibodies. Genetic factors do play a role in type 1. Polymorphisms of multiple gene HLA types alleles have a greater effect. HLA DR3, DR4 and DQ8 have shown to influence the risk of IDM type 1, and HLA DR2 confers protection, but it is not clear whether these findings in the West could be extrapolated to all the population. Environmental factors for type 1 infection like Coxsackie B virus and mumps, and these viral infection before the onset of diabetes, there is a history, is trigger the autoimmune system. The most common autoantigen seen in type 1 are insulin, insulinoma, or associated protein IA2 and IA2A, glutamic acid decarboxylase, and zinc T8, a zinc transporter of islet cell present within the pancreatic beta cells. And then pathophysiology of type 2 diabetes. Globally, 90 to 95% of people are affected with type 2 diabetes is characterized by hyperglycemia due to insulin resistance and relative insulin deficiency. Endogenous insulin secretions can be normal or insufficient, and insulin or compensatory mechanism in the initial phase is activated and insulin secretion increases, which help to maintain normal blood glucose level, but over a time the insulin secretion gradually decreases as disease progresses. Insulin resistance is recognized mainly by muscle, liver and adipocyte level, can cause increase in lipolysis and circulating free fatty acids, which further decrease insulin sensitivity at the cellular level, impair pancreatic insulin secretion or exhaustion. All these contribute to the development of the progression of type 2 diabetes. Along polygenetic nature, onset of type 2 diabetes is strongly influenced by environmental factors, sedentary lifestyle, urbanization, race of ethnicity, energy dense food intake, which ultimately leads to obesity. Insulin deficiency or insulin resistance. This further gets aggravated by other environmental factors like stress, depression, low birth weight and aging. The so-called Asian Indian phenotype refers to certain unique clinical and biochemical abnormalities in Indians, which leads to this abdominal adiposity, higher waist circumference despite lower body mass index, and lower adiponectin and higher levels of C-reactive protein. They are the inflammatory markers. Asian Indian phenotype makes individuals more vulnerable to metabolic syndrome, insulin resistance, diabetes, and premature coronary artery disease. And coming to the genetic factors of the pathogenesis of type 2 diabetes, various genomes are involved in type 2 diabetes. In India, 3/4 of type 2 diabetic patients have first degree family history of diabetes, and it suggests familial aggression and aggregation. Genes that are associated with beta cell function and insulin secretion, release, and action were implicated in the risk of type 2 diabetes. TCF7L2, the polymorphism, found to be defective in several populations. However, certain genes that are unique to Indians and predispose them to diabetes compared to Caucasian. On the other hand, some genes that offer protection to diabetes among Caucasians do not confer such protection to Indians. Environmental factors, we know lifestyle today is so different with increased motorization, urbanization, unhealthy dietary practice, especially the energy dense, quick to eat foods, and combined with a couch potato lifestyle, like a sedentary lifestyle with lot of physical inactivity, not activity. Indian diets are always been cereal staple and predominantly derived from refined cereals such as polished white rice, as against the earlier decades where we consume less processed grains, and almost half of our daily calorie intake and comes from refined grains. They are high in carbohydrate. Increased carbohydrates from refined grains increase the plasma glucose, insulin, triglyceride, and worsens insulin resistance. Besides genetic factors, excess consumption of calorie foods and sedentary lifestyle increase the risk. Now, as a result of this excess calorie consumption leading to positive energy balance, obesity is very, very prevalent. It's rising globally at epidemic rates. With the same trend seen in India, study has indicated that nearly 50%, that means every alternate Indian is a obese or overweight person. While genetic factors certainly do have a role in obesity, the sharp rise in prevalence suggests that many environmental factors, including diet, exercise, education, and socioeconomic status, play a key role in intensifying the problem. Obesity is a contributing factor to insulin resistance and cluster of metabolic derailments, leading to a condition called metabolic syndrome. And insulin resistance is the hero of the metabolic syndrome. The term insulin resistance refers to a physiological condition in which cells fail to respond to the normal actions of the insulin hormone. The body produces insulin, but the cells in the body become resistant to insulin and inefficient to use, leading to hyperglycemia. Pancreatic beta cells increase the production of insulin and contribute to hyperinsulinemia. Insulin resistance impairs uptake of glucose, amino acids, and fatty acids. This insulin and glucose are very important. It is a basic nourishment. Every cell of the body needs glucose, and brain utilizes glucose only purely. So the important role of insulin not to be forgotten at all. You must remember it very well. Such a central hormone. Role of intrauterine development has been widely researched. There is a proven relationship between birth weight and risk of type 2 diabetes in later weight. Even low birth weight and high birth weight are also associated with type 2 diabetes. Thin underweight baby having excess body fats, called thin fat Indian syndrome, higher risk for type 2 development. This may be possibly due to insulin defects in secretion, increased peripheral insulin resistance in muscle. In addition, premature or preterm babies are also more prone to risk of type 2 diabetes due to catch-up growth in the later adolescent phase. The symptoms of diabetes in general. Now we know the pathophysiology, how it is expressed clinically. Some may develop symptoms like excess urination, polyuria, thirst, and excess hunger, and some have urination at the night or bad breath and sudden weight loss or itching in the private parts or extreme tiredness, numbness, tingling sensation, or a wound which will take longer time to heal. They'll think of diabetes. Frequent infection, but Very important to know, not that every diabetic gets a symptoms. Symptoms are absent in half of the people, and hence it is also called a silent killer, which we have been saying it right from the beginning. It is asymptomatic. Many a time it is diagnosed during a routine checkup for a master health checkup or a pre-employment or a pre-surgery checkup. And the pathophysiology of GDM is due to increased production of estrogen, progesterone or beta cell, leading to hyperinsulinemia, resulting in low fasting blood glucose, whereas during second and third trimester, like placenta, lactogen, prolactin and cortisol, where counter-regulatory hormones leads to insulin resistance. However, in normal pregnancy, the insulin resistant and diabetogenic stress is answered by compensatory increase in insulin secretion, which is adequate and appropriate during pregnancy. Only when this compensation is compromised, a clinical picture of gestational diabetes mellitus sets in, and which has a risk for progression to type 2 diabetes if proper corrective measures are not taken postpartum or post pregnancy. So today's class we have seen the importance of diabetes. How did we assess the importance of diabetes? Showing the gravity of the situation in the global overview picture with the prevalence and number of millions of people living today, and what can be done. The good news we learnt is diabetes once gets in, it's going to stay permanently. It can be prevented. So what are the various measures one should take to prevent diabetes? To do that, we had to go through to understand how do we pick for people at risk to screen diabetes and detect them early, to know the pathophysiology, symptoms and all the related basic understanding of the diabetes. I am sure you all have learnt. With this sufficient knowledge we have acquired now at the end of the session, it should be enough for us to take on to the next module, where we will be going through to learn and understand what happens if we don't pay enough attention to take care of diabetes, either to prevent or to manage. What are the other complications are in store for that? That will be the next module.